last time I was here, I think that was probably April. But my name's Kenny Navarro. I'm an assistant professor at UT Southwestern in Emergency Medicine Department, and I'm going to be the CE instructor today. So on the very back table, there's a roster. Everybody make sure that you sign the roster before you leave, and there's also a CE certificate back there. So that's your proof. That's what the Department of Health will be looking for if they were to audit you about your CE record. And so I don't know what you do with them after you leave here, but whatever you do with them, that's your certificate. Okay, so we're going to talk a little bit about capnography in the beginning, and at the very end of this, we're going to have a practical application of capnography. So we're going to go through a case where capnography actually is very useful. Throughout the day, certainly if there's any questions, don't hesitate to ask. I think that probably for some of you, this information is you've had this before when you went to paramedic school, but depending upon when you went to paramedic school, so capnography's only really been in the EMS world for probably 20 years now, and if you went to paramedic school before that, you probably didn't get much training on capnography at all. Okay, so let's get started. Also, if you need to take a break, so if you have to go to the bathroom, just get up and go. We are going to take some breaks throughout the morning, but I would prefer that you just get up and go to the restroom if you need to, rather than try to hold it and get a kidney stone or something. Okay, so let's get started. Now, I think in order to understand capnography, and I hate to do this to you, but you got to really understand this this formula. If you understand this formula, then it makes capnography a lot easier. So the most efficient form of energy production that we have in our body is burning of glucose. That our cells will use glucose for energy. Now, not every cell in the body uses glucose the same way. So your heart, for example, doesn't get all of its energy needs directly from glucose metabolism. Your heart runs on about a 50-50 mixture between glucose and fatty acids. So one of the cool things about the heart is that in periods of low glucose states, the heart can actually switch over to full fatty acid metabolism and just keep on pumping. This is why you hardly ever see arrhythmias when you're dealing with hypoglycemic patients, because they don't have arrhythmias. The heart doesn't get into trouble, from generally speaking, from hypoglycemia. Now the brain, on the other hand, gets almost all of its energy from glucose. So as glucose levels begin to go down, that's the organ that's going to have the first indication that there's a problem, because the brain can't switch over like the heart can. But most of the cells out in your body are using glucose, and they're sort of going along this formula. Now this formula, this cellular respiration, is what this entire process is called. And really I've put just a very simple, you start off here, and then ultimately you're going to end up over there. But this is probably an entire semester, college semester, of how you get from glucose all the way over to the other side. We certainly don't have time, and it's not really necessary for us to understand every step along the way. But there are a couple of things that we need to remember about this, and that is, obviously, the cell is going to have an adequate amount of glucose. The cell is going to have an adequate amount of oxygen. And when it does, then ultimately, as it goes through the process, you're going to end up with water, carbon dioxide, ATP, which is the energy molecule of the body. And I like to think about ATP as being sort of like a buck, like a dollar. And so this is what the cell has to spend in order to make things happen. And so the more ATP that a cell can generate, the more activity that cell can engage in. And then, because this is not a completely efficient process, some of the energy is going to get lost along the way, and that will be the heat. So that's sort of heat that contributes to our body temperature, but it doesn't necessarily contribute to cellular processes. Okay, any questions there? All right, so the only thing out of that entire, on the other side, the only thing that is considered to be waste is the carbon dioxide. That's sort of the leftover pieces of this entire process. And carbon dioxide then is the waste product that the cell has to get rid of. And so all of that over on that side, where ultimately you're going to end up with the ATP, the carbon dioxide, and the water, that's going to end up in a little piece of the cell, inside the cell, called the mitochondria, where all of that reaction is going to take place. The mitochondria then dumps the carbon dioxide to the outside, sort of throws it out into the hallway for the cell. The cell then throws it into the hallway for the body. The blood supply will pick it up, move it to the lungs, where during expiration we're able to get rid of it. So we have to have some, and we can't get rid of it completely. There's going to be some levels of carbon dioxide always in our body, but especially when we start to make too much, then we have to get rid of that excess. In situations where we've gotten rid of too much, then we have to retain some so that we can keep our levels within a certain amount. Okay, any questions there? Okay. So now let's look at this first part of the process, glucose with the oxygen. So the very first thing when you eat and when glucose goes into your system and the cell receives the glucose, the first thing that's going to happen is the cell's going to start to break down that glucose. And there's a 10-step process that requires no oxygen whatsoever, and ultimately you're going to end up with this thing called a pyruvate molecule. And this will produce a little bit of energy, like 2 of the ATP, 2 of the dollars of the ATP that the cell can actually use. But you're going to end up then with this pyruvate molecule. And all of this takes place inside the cell, but outside the mitochondria. I know this can get a little tedious, but there actually is a method to understanding this. We're going to see in a moment. So the pyruvate then, once it's created, can move to the inside of the mitochondria where the rest of the reaction can take place. But it can only do that if there is oxygen. This is the reason that you need oxygen. If you don't have oxygen, pyruvate can't move to the inside of the mitochondria, and you can't extract energy any further. You can only get that 2, and that's it. So your body then, in a situation where there's not any oxygen or there's not any glucose, is going to have to find something else to burn. And as I mentioned, in some cases, the heart can actually start to burn fatty acids at a higher rate. Your muscles can start to burn fatty acids and protein at a higher rate as well. So that they can start to extract energy, but they're not getting it along the normal pathways. Okay? All right. Now, as I mentioned, if pyruvate has the oxygen, it will continue on into the process, and ultimately you'll get everything that you need. And then the first reaction to the pyruvate will give you 2 of the ATP dollars, but then the rest of the way will get you an extra 36. So you end up then, this is the most efficient way to get the ATP dollars. If you have to burn fatty acids or protein, you won't end up nearly with as much ATP, and you'll start to end up with some byproducts that are actually quite harmful. Okay, any questions there? All right. So now we've seen then how carbon dioxide is going to be made. Let's now talk about how we get rid of it and how we measure it. So the amount of carbon dioxide that you can actually detect when you put the sensor at the nose or the sensor at the end of the endotracheal tube, there has to be 3 things working in order for you to get that number. You have to have metabolism, which is what we just saw. You have to be creating the carbon dioxide. If you're burning fat, you won't create carbon dioxide. If you're burning proteins, you won't create carbon dioxide. So the carbon dioxide that you're detecting indicates that cellular respiration is occurring somewhere in the system. Okay? Now, obviously, if you have a situation where you have hypermetabolism, where cellular activity is up, like a grand mal seizure, for example, then carbon dioxide levels are going to go up because the cells are working very, very hard, going through cellular respiration and producing lots of carbon dioxide. This is why after a seizure, when you put a patient on capnography, you see that the CO2 levels are on the upper end of normal, or they're just outside the normal range. Okay, does that make sense to everybody there? All right. And then on the other end, if you have, I know that doesn't happen very much here, but if you had a situation where a kid falls through ice and is pulled out of the water 45 minutes later, their metabolism is so low that they're barely producing any carbon dioxide at all. And so if you put them on CO2 and they are breathing, then your carbon dioxide measurements are going to show them to be very, very low until they start to warm back up. All right, so you have to have metabolism. You also have to have an intact circulation system for things to be normal. And so the circulatory system, of course, what happens is that once the carbon dioxide is made out in the cells, it has to be moved through the heart to the lungs, and finally the alveoli have to be ventilated. So you have to have all three things working in order to get normal numbers. And if you have something within the normal range, that means metabolism is normal, circulatory system is functioning normally, and the ventilatory system is functioning normally as well. When you apply capnography and you get a number that's outside of that range, it means that something here is messed up. It doesn't tell you exactly which one it is, but it tells you that something is messed up, and you then have to figure out the situation and fix it. Find out where the problem is. Okay? Does that make sense to everybody? So, if I remember correctly, you guys are using LifePak 15s, is that right? Okay. So the way that your LifePak 15 works, this is how capnography works, is that there's a small sample of the patient's exhaled breath that is sucked into the machine. And then your sample, or that sample of the breath, is compared to a known sample that's within the machine itself, something that has a known concentration of carbon dioxide. Infrared light is shown between, or is projected between or through the exhaled breath and the known sample, and on the other end there's a sensor that's measuring how much infrared light is coming through those two essential samples. Now, carbon dioxide absorbs infrared light at a specific wavelength, and it absorbs it pretty constantly. So the more carbon dioxide you have, the more infrared light is going to be absorbed. And this is how this works. So when you compare then how much infrared light is coming through the unknown sample to how much is coming through the known sample, then you can get an estimate of how much carbon dioxide is actually present in that known sample. And that's the number that you get. Now you should also be aware that what you're getting doesn't necessarily represent the exact amount of carbon dioxide that is present in the blood supply of the patient. It's just an estimate. And so the number probably differs by 3 to 4, maybe 5 percentage points, plus or minus, in what's actually there. But it's a pretty good estimate of what is in the system, of what is in the patient's bloodstream. All right. Now this all became possible for EMS because of something called side-stream sampling. In the days before side-stream samplers came along, everything was mainstream sampling. So capnography was pretty much confined to the operating room, where they would have these stands, and you'd have this machine that they could slide into position on an endotracheal tube. The breath from the endotracheal tube would come through this machine that was being supported by stands, and the same sort of process would work. So when side-stream sampling started to come on board, probably around the year 2000, then it allowed the hardware to be in a machine, and you could just pull the sample over to the machine rather than place the machine in line with the breath. And so this is what made it possible. Prior to that, then there just wasn't any way to measure this in the field. Okay, now this is the sample of this cuvette that you can place on an endotracheal tube, or you can place it on a supraglottic tube, or you can place it just on a BVM mask, and it works pretty well. You guys are also all familiar with the nasal cannula type devices that some of them have where you can give oxygen through one of the little nasal prongs, and then it's measuring carbon dioxide in the other nasal prong. There's also a mask that does something very similar that allows you to give the patient oxygen, but then it has another little thing that you plug into your machine where it's going to take a sample of that air and see how much carbon dioxide is in it. Okay, questions there? All right. So this is what a normal waveform looks like, and we're going to go through the phases in a moment because it's important to understand how this waveform is created, because just like with an EKG, you can look at, you can have a pulse, right? Someone can tell you what the patient's pulse rate is, and that's pretty good information. But if you can see the EKG, it is telling you some specific things about the heart that you wouldn't be able to get just from a pulse. So knowing the patient's number is a great tool, but also looking at the waveform, just like the EKG, will tell us specific things when you see abnormalities. All right, so end-tidal CO2, you'll also see me refer to it as PETCO with a P in front of it. The American Heart uses PETCO. Lots of people are now beginning to call it PETCO. It doesn't make any difference. It means the same thing, whatever terminology you use. But this is essentially the end-tidal carbon dioxide measurement. The normal range is between 35 and 45. For every place on this planet that human beings live, it's about 35 to 45. Now, if you were to take a sample of about 100, 200 people from Allen, and everybody, you get an end-tidal CO2 reading and you average it, the average reading for people at this sea level is going to be about 38. So I know that 35 and 45 is your range of normal, but you need to start thinking about 38 as being the normal. And then things that are above that start to get abnormal. Things that are below that start to get abnormal. And the further you are from 38, the more abnormal it becomes. Okay, does that make sense? So you think about then, if you have a patient at 44, 44 is still within a normal range, but they're a little bit high from what you would expect to see, because you would expect to see 38. And so at 44, even though it's still within a normal range, that's still a little bit high, and it might be worth investigating to try to figure out why that number is a little bit higher than what you would expect to find. Okay? All right. Now, if you have numbers above 45, an end-tidal CO2 reading above 45, and everything else is working normally, metabolism is normal, the circulatory system is normal, and ventilation is normal, numbers above 45 suggest that the patient is hypoventilating, meaning that you're not able to blow off the carbon dioxide as fast as the cells are making it. So that is a hypoventilation state. On the other hand, if it's below 35, then it is hyperventilation. You're blowing it off faster than the cells can make it. Okay, any questions there? All right, so let's go through the process of creating the waveform. So let's start off in the beginning. So the very, very beginning part of the waveform is called the respiratory baseline, and that is this area between A and B. So notice that phase 1, the respiratory baseline, has a value of 0. And what that suggests then is that as the patient begins to exhale, the very first part of exhalation, there's no carbon dioxide present in their exhaled breath. And the reason for that is that you think about when you inhale, you're sucking in atmospheric air. There's no carbon dioxide in this room in any appreciable amounts. All right, you have like 0.04 percentage of this room is carbon dioxide. It's a negligible amount. So we can essentially say it's 0. When you suck in air on your inspiration, you're filling the entire airway with air that doesn't have any carbon dioxide in it. So in the back of your throat, in the trachea, in the bronchi, where there's no gas exchange occurring, that's all filled with this atmospheric air, with this room air. We call this dead space in the respiratory system because it's not participating in gas exchange. So the very first thing you have to do in exhalation is you've got to push all that dead space gases out. And in the first part of expiration, there's 0 carbon dioxide in it. Okay, is everybody with me so far? All right, now at point B, the very first alveolar air starts to make it to the exit. And if we think about having the sensor here at the nose or at the mouth, the very first alveolar air starts to get out. And that's going to come from the alveoli that are closest to the exit. All right, so we start to see the numbers go up. And the number's going to go up relatively quickly. because we've pushed most of the dead space gas out, and now the alveoli are starting to empty from the lungs. So it's going to go up really, really quickly. The closer you are to point B, the more dead space gas there is. The closer you are to point C, the less dead space gas there is, and the more alveolar gas there is. When you get to point C, then pretty much all the dead space is out of the system, and now it's almost entirely alveolar air. And so because the concentration of carbon dioxide is essentially the same in all of the alveoli, if you're pushing alveolar gas out, it doesn't matter which alveoli you're pushing out. The carbon dioxide levels are going to be relatively constant, and that's why phase 3, the plateau, seems to level off. On your monitor, sometimes this can appear almost as a flat line, but if you could get down to a really, really tiny level, there's actually, all of them are going to have a little bit of a slope to them. It just may be very difficult to see the slope in the very beginning. All right, so this plateau, assuming everything is working correctly, should level off here within the normal range. Now the point D value at the very end of phase 3, and all of this, by the way, is exhalation. So point D value represents the Petco, the number that you get on your monitor. When you look over to see what the CO2 level is, it's measuring it at point D. And it doesn't change. It won't actually start to go up, down here in phase 2 and then rise quickly to the highest level. It's only going to be measuring right at the beginning of inspiration how much is there. So that number can change, but it generally doesn't change too much. Okay, questions there? All right, now point D also signals the end of, or the beginning of inspiration. And as we mentioned, when you're measuring here at the sensor, you start to breathe air in. The air that's going to be passing by the sensor now has 0 carbon dioxide in it. So phase 4, the inspiratory phase, is going to drop very rapidly to 0. And then the whole system is going to start, the whole cycle is going to start all over again. So when we look at this waveform, then we can see the first 3 phases are exhalation, the 4th phase is inspiration, and this is really measuring then, or sort of graphically depicting what it looks like to have gas flow in and out of the lungs. So if you see abnormalities from this box-like configuration, then what that means is something is interfering with the gas flow in or the gas flow out. So once again, it's very similar to an EKG. We all know what normal sinus rhythm looks like, but when that ST segment changes configuration and it no longer looks the same, that tells us something specific. When the QRS is a little bit wider than normal, then we know that that means something specific. Right? Even though the patient's pulse might not have changed, we know something along the electrical conduction system of the heart is kind of screwed up. So this is telling you about the pathway of the airway. Okay, questions there? Okay, so let's go through a little bit of a couple of exercises here where we're going to look at abnormal capnogram patterns. And one of the most important things to remember is that if you have an abnormal waveform, then you have an airflow problem. There's a problem with the flow, and you have to figure out what that problem is and fix it. Okay, so first one, tell me what's abnormal here.
Not getting all their air out of the lungs.
Yeah, so is this an inspiration or an expiration problem? It's inspiration. So it's happening over in phase 4. Remember that these first 3 phases are expiration, and then when you get to point D, this is inspiration. And so this is should fall all the way to 0, but it isn't. It's falling to 10 and leveling off. And so what this is called a rising baseline. And this will continue over time. So if you didn't pay any attention to this, that baseline would rise with every breath that you take. It may not be dramatic, but if you have rising baseline that starts in the house, and then 15 minutes later you're at the hospital or you're on the way to the hospital, what started off as a 10 may now become a 15. And so it's going to gradually start to move up. And what rising baseline means is that when you are pulling air back into the system, it doesn't have 0 carbon dioxide in it. It has some level of carbon dioxide in the air that they're pulling back into the system. And if you're pulling carbon dioxide back in the system, it's going to start to back up in the bloodstream as well. It won't be able to cross that membrane to the same degree. And so the patient here is rebreathing their carbon dioxide, and the carbon dioxide levels are going to start to go up in the patient's bloodstream. So now you have to figure out why this is happening. If you have the patient on a non-rebreather mask, for example, this could happen when a patient, that all of that exhaled breath is not being cleared out of the mask. And so they exhale, and they're breathing in their exhaled air. So you might want to crank the oxygen up just a little bit. Or those valves may not be working properly. You may have to switch the mask out completely. Okay, questions there?
Or you might need to turn the oxygen on.
Or turn the oxygen on in the right if you've forgotten to do that. Take the paper bag off their face, or whatever it is that's causing them to rebreathe carbon dioxide. Okay, now tell me what's wrong with this. First, is it an inspiration or an expiration problem? It's expiration. So this is a phase 2 problem. And remember, in phase 2, you have dead space gases being pushed out relatively rapidly, and the alveoli start to empty. So here is all dead space, and then you start to have alveolar gas. Now normally, in order to get to this level, you'd be way over here, and it would only take this amount of time. But now it's taking much, much longer for that alveolar gas to get out of the system. So this, everybody knows this as the shark fin pattern, but what this is telling you is there's bronchoconstriction. It is a delayed upstroke. It's the delayed phase 2. The patient is having trouble getting alveolar gas out, and now you have to figure out why. So this doesn't tell you that the patient is asthmatic. It doesn't tell you that the patient is having an allergic reaction. It tells you that they're bronchoconstricted. And then you have to figure out what is causing the bronchoconstriction and fix that. Now the good thing is bronchoconstriction is fixed in many cases the same way. It's give them a bronchodilator. If this were anaphylaxis, then they might also need an IM epinephrine. But the bronchodilators would be the appropriate thing. Now, one of the other cool things about bronchodilator therapy is if this is what you see when you first put the patient on the monitor, and you ask the patient, you listen and they're wheezing, and you ask the patient if they're having a hard time breathing, they say yes, very severe time breathing, really hard. And you start them on bronchodilator therapy, and then maybe after that first bronchodilator, do you feel any better? They may say no. But if you start to see this waveform taking more of a box lot, it's starting to come back this way, then it suggests to you that your medications are working. They may need a second dose, but you can see that your medicines are working. They just can't feel it yet. On the other hand, if you get to that first one, get past the first one, and this hasn't changed at all, then it may mean, well, of course you're going to start a second one, but it may mean that your medications are not as effective as you want them to be. Okay, does that make sense to everybody? So sometimes you can actually tell that the patient is getting better even when they can't tell that they're getting better. Okay, so now, tell me what's wrong with this one. Inspiration or expiration problem? It's inspiration. So it's happening over in phase 4. Notice that 1, 2, and 3 are all normal. But over in phase 4, normally that should be coming to 0 relatively quickly. And this is taking a lot longer period of time to get to 0. So this is a prolonged phase 4 problem. This is pretty rare. You don't see this very often. And a couple of things have to be in place for you to see this. So remember that this is an inspiratory problem. So it means that the patient is going to have to be breathing in order to do this. And remember also that what this represents is the sensor here. Air is coming past the sensor with no carbon dioxide in it. And if it's normal, it would be here. But now air is coming past the sensor with no carbon dioxide, but it's not clearing this sensor as quickly. It takes a little bit more time to get it to zero. So what has to be in place usually for this situation is that the patient has to be intubated. For an adult patient, what it suggests is that your endotracheal cuff has deflated, and the patient now, when they take that breath, they're sucking air around the tube and through the tube at the same time. For pediatric intubation, where you have no cuff on the tube, it would suggest that your tube is too small and it's not sealing, so that infant is taking a breath and sucking air around the tube and through the tube at the same time. Okay, so you can see why that would be rare, because you'd have to have intubated patients who are actually breathing. Okay, questions there? All right, so now there's some times where the waveform is normal, and remember that normal waveforms mean normal airflow. Okay? Abnormal waveforms means abnormal airflow. Sometimes the waveforms are normal, but the number is screwed up. The number is not within the normal range. So even though this would actually never happen, tell me what you see that's wrong here. So you would never see, within a span of 5 breaths, endotracheal or tidal CO2 levels rising, doubling over a 5-breath period. But you might see a situation where you're in the house with this, and by the time you get to the ambulance, you're over here. And you just notice that the number has come up, where you didn't really notice it before because all you were looking at were the waveforms. So what this is telling you, what this trend is telling you, is that the patient is hyperventilating. They're making carbon dioxide faster than their body's getting rid of it. And so if you see this, then, and again, assuming that you have normal circulation, normal metabolism, then you might have your partner pick up the pace of ventilation just a little bit. Not crazy. You don't want to go from 10 to 40 all of a sudden, but go from 10 to 12 and see if that number starts to come down. Okay? If you have a patient that isn't intubated and you see this happening over a period of time, then you might consider whether you need to take control of that patient's airway, because the patient clearly isn't ventilating properly for themselves. Okay? All right, how about this one? This is just the opposite, where it is hyperventilation. And this is one that you really want to pay close attention to, especially in a cardiac arrest or post-cardiac arrest situation. Because once again, you might have, and again, over 5 breaths, it's not going to be this dramatic. But over a period of time, you're just going to see the numbers gradually getting lower. And so one of the things that you can do with your, if you have someone who's bagging the patients, is they can use the numbers and the respiratory rate. You can actually fixate your partner on those numbers and say, I want you to sit up here in the airway and squeeze this bag 10 times per minute, and you can see the 10 on the screen here. Don't let it go to 12. If you go to 12, you're going too fast. And I want my numbers between these particular values. So if you start to see the numbers go up, let me know. Somebody get my attention, so that then you can start to pay attention to whatever it is that you need to pay attention to. Questions there? All right, how about this? Tell me what you see that's abnormal. And this could actually happen. Go ahead, you can just say it.
It's bad seal or BVM.
All right, so here we see, first of all, all of the waveforms have the box-like shape. So it all indicates that the air is flowing in and out of the system appropriately. But here you've got end-tidal values that are somewhere near 40. And And then all of a sudden here, they're about half of where they were within the span of one breath. So let me ask you this question. Do you think that it's possible within the span of one breath to know, well, first of all, somebody tell me why this is not a respiratory problem, why you know this is not the respiratory system doing this.
Because it doesn't happen in the span of one breath.
Because here was a breath, I expected my next breath to be right here, and it came when it was supposed to. So this is not the respiratory system, meaning that it has to be metabolism or it has to be circulation. So let me ask you, do you think that it's possible within the span of one breath to cut carbon dioxide level, your body to cut carbon dioxide production in half within that couple of seconds? Is that possible? And the answer is no, it's not possible. Even if your heart completely stops, even if you go into cardiac arrest, you will not, cells in your body won't even know that your heart has stopped for an hour. Down in your muscles and your legs, those cells are just going to keep doing what they do for the next hour or 2 hours or so because they have stored oxygen, so they just keep working. Now pretty soon those cells get into trouble and they realize that something has happened. There's nothing they can do about it, but they're going to learn eventually that there's a problem. But they're not going to know right away. So it doesn't seem likely that this is suddenly this patient had metabolism in the body cut in half within the span of 2 minutes. That just doesn't seem likely. So now, do you think it's possible to cut carbon dioxide elimination in half within the scope of one breath because of circulation? Remember that circulation has to move the carbon dioxide to the lungs. So could you be moving half of the amount of blood within the span of one breath? Can that happen within the span of one breath? And the answer is yes. If you go into cardiac arrest, you can take this all the way to zero. It can go that quickly. You have no cardiac output at all. So it is possible that this could happen. This is not a respiratory problem. This is not a metabolism problem. This suggests to you that something catastrophic has happened to the circulatory system. And you have to figure out why. Now this could be, maybe this was that inferior wall MI that you didn't really pay much attention to. You popped a nitroglycerin in their mouth. Or maybe you forgot to ask them about erectile dysfunction drugs. You tossed that nitro in there, and then a couple minutes later, bam, all of a sudden his blood pressure drops. And then you see this happen. Now hopefully it is something simple like that, because then you just get them over the next 5 minutes and they're going to be fine. Nitroglycerin wears off pretty quickly.
Could it be an occlusion in the end tidal?
So yeah, it could be, it has to be some kind of constriction. Yeah, but assuming that this is not a connection problem, yeah, something like that. Now, one of the other things that this could be is maybe this is a patient you haven't even put on a monitor yet. He's having crushing, worst type of chest pain he's ever had. And then all of a sudden, as you're putting him on monitors, he goes from here to here, but you don't have the EKG on. It could be that he's now developed a lethal ventricular arrhythmia right in here. They've gone into VTAC, which is going to go into VFib pretty soon if you leave it alone. So you need to get him on a monitor and see if that's what the problem is, so you can fix that with a shock. Okay, questions there? Now the one that you all know is this one. Everybody should recognize this. So we're going to make the assumption that you have the patient intubated, you have your partner delivering breath, and they deliver, and then all of a sudden your partner is up there squeezing. Maybe you loaded the patient into the ambulance, and the partner, you look up, is still up there squeezing the bag on the ET tube, but this is what you see on the monitor. So what is that? The tube has become displaced. Yeah, the tube has gone somewhere, probably into the esophagus, but it's no longer in the trachea. Whatever's coming back up that tube is not gases from the lungs. It's gases from somewhere else. And again, it's assuming that somebody's still squeezing the bag or that the patient is still breathing. What this suggests is that your tube has become dislodged. Okay. Question there. Now this is the reason that waveform capnography came to the EMS world in the first place. There was a couple of really important papers that were published in about year 1999, I think, where I think one was in Orlando, where they looked at what percentage of endotracheal tubes that were placed by paramedics when the patients arrived at Orlando Medical Center, where the tube was now in the esophagus, and it was dislodged and the paramedics didn't know it. Now in that system they didn't have waveform capnography, and what they found was it was over a third of the tubes that the paramedics were placing in the field had migrated into the esophagus by the time the patients arrived at the hospital. We did a similar study within the Vitel system in the year 2001, and we found the same thing. About a third of our tubes had migrated into the esophagus, and the paramedics didn't realize that had happened. And so with it at Orlando Medical Center, what they did was that they went in then to the fire department and they bought waveform capnography. And then they trained everyone to use it, and they monitored tube placement for the next year. And they found that the numbers fell from 33% to 0%. There was not one case of unrecognized esophageal intubation upon arrival in the emergency department. So we did the same thing in Vitel in 2002, and we found exactly the same thing. We went from 33% to 0% within 1 year. Now the second year after introduction of waveform capnography, there were 2 tubes that migrated into the esophagus and were unrecognized by the paramedics. And what do you think was common between those 2 cases? It was 2 different medics, 2 different ambulances, but what do you think was common? They secured it the same way, but they didn't put waveform capnography on the tubes. So, and their excuse was they were too busy. They had too many other things to do. And in both of those cases, they ended up with an esophageal intubation. So one of the things that I do sometimes as sort of a side job is I'll get phone calls from lawyers who are representing paramedics who are being sued. Almost every case that I've done so far has been some airway misadventure. And they'll say, will you take a look at the chart and tell us how strong our case is? We're defending the paramedic. And how strong is the case? And in one of the cases that I remember, I read through the chart, and I felt really bad for this medic because he tried for a very long, he had something like a 30-minute transport, and he couldn't get control of this airway for the entire 30 minutes. And finally, as they were backing into the emergency department, he got the tube. And so they went into the emergency department, but it was an esophageal tube. And I felt bad for him because I can't even imagine 30 minutes and he can't get control of this airway. He's doing everything he knows how to do. He's in the back all by himself, so there's nobody to help him. And I said, well, the problem, first of all, this medic, I feel really bad for him. And the problem is with his department. His department put him in a situation where he can't win because he didn't have the training. He didn't go through CE on endotracheal intubation very often, and they didn't provide him with waveform capnography. He's got a $3 stethoscope trying to listen to breath sounds in the back of a moving ambulance with tensions already pretty high. And I think that his department is negligent for putting him in that situation. And so the attorney said, well, tell me about waveform capnography. And when I explained it to him, he said, oh, they had that. They had waveform capnography. He just didn't use it. And then in the deposition, he didn't use it. And he said, I didn't use it because we were just pulling into the emergency department and it didn't really have time to put it on. And so now what he has is a chart that shows that he put a tube in the patient's throat, didn't check placement at all, and when they arrived in the emergency department, they have documentation that it was an esophageal tube. And so my advice was, you settle this case out of court because you're going to lose if you go to court. So this is one of those things, and I realize that now we're 20 years after the fact, and I don't have to remind you how important endotracheal waveform capnography is on endotracheal intubation, but I'm sure that you guys are pretty close to 100% of the time you're using it, but it is critical, and it will save your rear end. That information is actually stored in your machine as well. So when you arrive at the hospital, if you have emergency department personnel who say this tube is improperly placed, you actually can go back into your machine and pull a code summary and show them that it wasn't. And that's probably a good idea for you to do anyway, to have a record, because then when you go to court, you can say, yep, we have a record that shows that upon arrival in the emergency department, there was carbon dioxide coming up out of that tube, and that couldn't have been happening if this were in the esophagus. Okay, questions there? All right, now having said that, I want to tell you a little bit about some of the limitations. So waveform capnography does have some limitations on endotracheal intubation in children. In a study of 153 pediatric patients who underwent cardiac catheterization who were intubated, 18 of them, which is about 12%, had right main stem bronchus intubation. So the endotracheal tube can't differentiate between normal tube placement and bronchus placement, either main stem placement. It can't tell the difference. This is why you still have to follow up with breath sounds, making sure that both sides are being ventilated. In the situation that I mentioned with 12% of these kids who had main stem intubation, all of them were under the age of 10 and 7 of them were under the age of 1. All of the children had what was recorded as bilateral breath sounds on their charts. So the medics heard breath sounds on both sides. And what the researchers believed was happening was that the tubes were being placed like this. So they were a little bit too far, meaning that the majority of the air was going where it was supposed to, or into the right lung. But because of the Murphy's eye that was there was also some going to the left side. So it is still possible to get bilateral breath sounds even with a tube in children, even with a tube that goes a little bit too far, at least in this particular study. Okay, questions there? All right, so besides visualization, the only thing that even comes close to waveform capnography is visualization. But that's only one person on your team that can see where it goes unless you're using fiber optic. And do you guys use video laryngoscopy?
Yes.
Okay, now is yours where you're here? Is your screen here, or is it over to the side?
This is right at the top.
Right at the top. Okay. And do your devices have the ability to snap a picture of that? No. Those would be ideal. You can see where that would be ideal. I pass the tubes, push a little button, snap a picture. That becomes part of the patient record, so you have something that shows that your tube was in the right spot. But besides visualization, because that's pretty accurate, right? If I can actually see the tube go between the cords, and I can look down there and see that, then I'm pretty sure that my tube is properly placed. But besides that, waveform capnography is the most accurate single method use or single method device of confirming tracheal placement, although it may be in the main stem as well. This has got, in research terms, this is called 100% specificity and 100% sensitivity. So waveform capnography, what those numbers mean is that if you have the tube in the trachea, you will produce a waveform. And if the tube is not in the trachea, you will not produce a waveform. So that's what 100% specificity and sensitivity mean. And there's no other device that comes even close to that. Even, interestingly enough, even visualization doesn't have 100 and 100%, because sometimes people claim that they see the tube pass between the cords, and all they're seeing is cords on either side of the tube, but the tube is actually in the esophagus. But when you look down, you can actually see cords on either side. You just forget to look on the underside. Okay, questions? All right, you guys all knew this information beforehand, right? I've never taught you anything really. Okay, so let me ask you a couple of other questions to test your knowledge. All right, now how about children and infants? Well, they have slightly smaller capnography waveforms because they have smaller tidal volumes. So will the kids' waveforms be shorter compared to adults? What do you think? Yes or no? No? Getting a lot of no's? Anybody disagree? The answer is no. So this is measuring a percentage of carbon dioxide in that expired air. It doesn't make any difference whether you're taking a shallow breath or whether you're taking a deep breath. The percentage of carbon dioxide is going to be the same. So it doesn't matter whether you're 1 or 101. All human beings with normal, healthy lungs, an intact circulatory system, and normal metabolism are going to be between 35 and 45. Now, the only thing that's going to be a little bit different on children is that you're going to see more of those waveforms per second or per minute because kids breathe faster. All right? Questions there? So I think I already answered this question. Is waveform capnography sensitive enough to detect right brainstem bronchus intubation? And the answer is no. So again, this is why you have to listen. You won't be able to tell that you have a brainstem intubation. In fact, in one study, they found that about 90% of brainstem intubations had normal end-tidal CO2 readings throughout the time that the tube was in the main stem. Now, obviously, they didn't produce. And you can see here the tube is being marked. Anytime you see arrows on an X-ray, it's a bad thing. You don't put arrows on X-rays that have good things. But here's on each ET tube, there's that line, that radio opaque line. That's what this is. And so it's showing this lung is getting air, and this one is not. Okay. Questions there? One of the other things I like about this is I want you to notice how far down the carina would be. So this would be where the carina, remember at the division between the left and the right main stem, this is going to be right about here. And I think sometimes we have a tendency to believe it's just below that little notch in our throat, but it's actually more about where you would place your hands for CPR. That's about where the division is. So that's how far you actually have to pass the tube to hit in the carina. This is why main stem intubations, you can almost see them just looking at it from above because there's only this tiny little amount of tube that's sticking out of the patient's mouth. And so you can just look at it and go, yeah, I think that's too far. Okay, questions there? Okay, let's run through this and then we'll take a break. So capnography and cardiac arrest. What I've been talking about so far has been situations where metabolism was normal, where circulatory system was normal, and where the ventilatory system was normal. One of the things that I think a concept that is sometimes a little bit difficult to get across, and we even have problems with this with the med students, is that when you're using capnography and cardiac arrest, the numbers mean something completely different. You can't take a value of 25 in a patient that has a pulse and make the same interpretation that you would make in a patient who doesn't have a pulse. The numbers mean something completely different. All right? So, during closed chest compressions, blood flow to the lungs is pretty low. Even if you're doing relatively good CPR, in fact, it's estimated that perfect CPR only moves at best about 1/3 of normal cardiac output. Some argue that it's about 1/4. So if you are doing absolutely perfect CPR, you're moving 1/3 the normal amount of blood coming out of the heart, which means that the lungs are only getting about 1/3 of normal, which means that with low perfusion, you have alveoli that are being ventilated with a bag, but they're not being perfused well. So end-tidal CO2 values are going to be much, much lower. And again, if you're doing perfect CPR, maybe you're getting 1/3 of what is a normal end-tidal CO2 reading. And so if the upper level of end-tidal CO2 is 45, then during CPR, you might be able to generate a 15. And that 15 means that your CPR is actually pretty good. Okay, does everybody understand that? Okay. Now, we actually would like to have the numbers a little bit higher, if you can get them a little higher. And some of you may have seen on your cardiac arrest numbers higher than 15 with chest compressions going on. Everybody see higher numbers in the 20s?
The Lucas device gets in the 40s.
Okay, so yeah, and I forgot that you guys are using a Lucas. And are you applying Lucases early in your arrest? This is not like just a transport thing.
No, it's early. I'll say
Okay, and all of your vehicles have it?
all the medics.
Okay, so a medic would have to get on scene first? Okay. So I'm not, I think Lucases are interesting devices. I think that the data is fairly good on the amount of blood that they actually can move. There's some good case reports on patients even who go to cath labs with a Lucas device on, where they can't get the heart restarted, but they know they've got a complete obstruction of a coronary artery. So they take them to a cath lab with a Lucas device on and do cardiac catheterization while the Lucas is performing CPR, and have great outcomes for patients that are having great outcomes. So I think that they're interesting devices. I think they have a lot of applicability. Sometimes the question comes up, do you recommend that, so I do lectures around the country, and sometimes I'll be in some small places and they'll say, we have $15,000 extra, we came from something and we're thinking about buying a Lucas device, what do you think about it? And my response usually is, how strong is their QI system? And if their QI system is not strong, that's where I think that they should put their money in, because you can actually do really good CPR manually if you train people to do it well. But the data as far as survival on with mechanical CPR devices is actually pretty bad. I think that there's probably a lot of methodological issues with those studies and may not be a reflection on the machine. But I'm off on a tangent now. Okay, so any questions about blood flow? So you can also see then that the more blood you can deliver to the lungs, the higher the CO2 values are going to be. Meaning, of course, that if you have someone, let's say that there's 4 or 5 of you on the scene and someone is performing chest compressions and they're producing a number of about 18. And then you switch and the second person that gets on there starts producing a number of 10. So do you think that 8-point difference, that 8-point drop is a reflection of the metabolic state of the patient, or the ventilatory state of the patient, or the circulatory state of the patient, or do you think it's the CPR person? It's the CPR person, the person who's acting as the artificial pump is not pumping well. And so whoever the team leader in that resuscitation would have to find a way to motivate that second chest compressor to push harder, because you know it's clearly possible to hit an 18. You just saw it in the last compressor. And then if you can't motivate your team member to get the numbers higher, then you have to find something else for that person to do, but they have to get off the chest. Hey, maybe they can go for the cot, send them for the cot, or go boil some water, or tear up some sheets or something, but let somebody else in there on the chest. Okay, so as I mentioned then, the deeper your chest compressions, the more effective your chest compressions, the more your carbon dioxide levels are going to reflect an increase. They're going to start to increase. It's been found that for every 10 millimeter increase in depth, which is about a half of an inch, so every ½ inch deeper, then you increase end-tidal CO2 by about 1.4, about 1.5. And so pushing as close as you can to the recommendation of over 2 inches is probably something that you want to encourage. Most people do a CPR too shallow, and that becomes problematic. So while I applaud your use of a Lucas device very, very early, you can see that in some cases the quality of CPR that occurs before that Lucas device goes on may make a difference in the outcome of these patients. And so the people that are doing manual chest compressions initially have got to be doing high quality manual chest compressions, or those that Lucas device is not going to show any benefit to the patient. And I think that that's probably some of the problems with the studies that are out there on them. Not every study has in some cases, for example, the studies would have one Lucas device for the city. It would be on a supervisor vehicle. Somebody would have to get on the scene, recognize it's a cardiac arrest, call for a supervisor who would then come to the scene and put on a Lucas device. So Lucas devices were not going on for 15 minutes at the cardiac arrest. And if you're doing really crappy CPR for 15 minutes, the Lucas device isn't going to come in and save the day. So whoever's doing that initial manual CPR has got to be doing really good, high quality manual CPR. So the American Heart Association actually recommends that you, even though we talked about 15 is good, if you can get 18, that's even better. If you can get 19, that's even better. And American Heart says you should be striving for numbers above 20, getting them above 20 with manual CPR. You're getting 40s with Lucas devices, so that's great. Now, one of the other things to be careful about with these numbers is that the numbers also depend on why the patient went into cardiac arrest in the first place. So if you have someone who's just walking through, or maybe they're a jogger, they have the big one, fall to the ground, you start doing chest compressions, you may get that 18. But if you have someone that's an asthmatic or a COPDer, and they've been having trouble breathing for hours and hours and hours, and now they've finally given out, they were already hypercarbic. They already had elevated CO2 levels in their system. So when you arrive on the scene and start bagging them and doing chest compressions, your CO2 levels are going to be much, much higher in those patients because they were asphyxial arrests. And asphyxial arrests can sometimes suggest that your CPR is really good when it isn't good. And so as you get further and further and further into this chest compressions, with bad chest compressions and an asphyxial arrest, those numbers are going to start to come down and show you where the patient really is, as far, or where your chest compressions really are. Does that make sense to everybody? So you just have to keep that in mind. If you have an asphyxial event, the numbers are not nearly as correlated with the quality of your chest compressions as if they just collapsed.
What do you do the same thing?
Anything that causes, so drowning, all of those things, anything that's asphyxial in nature. Okay. So now, adult cardiac arrests, there's a study where they tried to look at, is there end-tidal CO2 numbers that are associated with ROSC? And what they found that for patients who, in this particular study, and it was a pretty big study, now it's retrospective, which has its own limitations. But what they found was in that study, every patient who achieved ROSC, when you averaged out their end-tidal CO2, it was about 26 points, 26% or 26 millimeters of mercury, give or take 10 points there. So the fact that you're getting 40s is actually pretty good. You're giving your patients who have the best chance of survival an opportunity to survive the event. Now this is compared to those who didn't achieve ROSC. They could only manage 13s. So there isn't a number that is clearly, if you can get this number, you're going to get a survivor. But generally speaking, the higher the numbers, the greater the chances that your patients are going to survive. And probably you ought to start looking at survivors at about 25, 26 points, or 26 millimeters of mercury. If you can get them to that level, then they have a decent chance. They have as best of a chance of surviving as you're going to allow them. Okay, questions there? All right, now if you're monitoring end-tidal CO2 and this happens, this is probably not you. So remember that the waveforms are going to be created with your ventilations. So if you notice I'm down here, and then one time when I breathe, bam, we're way up here, there's a dramatic increase, that's probably not that your CPR has suddenly gotten better. What that suggests is that you have the amount of blood that you were moving here combined with the amount of blood that the heart is now moving because it's restarted or it's squeezing somehow. It may have been squeezing here, but not very effectively. And then now it's become effective. So when you see dramatic rises in end-tidal CO2, that's probably not the quality of your CPR. That's probably ROSC. American Heart is actually looking at trying to find a number to suggest, because think about this, right now I'm stopping every 2 minutes, stopping chest compressions to reassess my patient, recheck for pulse, see if they need to be shocked. Right, so I'm intentionally introducing a pause every 2 minutes, which we know pauses are bad. What if we could get rid of all those pauses, where you didn't have to stop until the patient actually did have a pulse? What if that were possible through technology, that you start and the only time you stop is when you're sure that the patient has a pulse, and the way that you would be sure is that they reach a certain end-tidal CO2 value. So American Heart is looking at that. So far they haven't been able to find what that number is that is suggestive of ROSC, but it is an interesting concept. I tell you what I think is going to happen in the future. So again, every 2 minutes we're stopping to check for a pulse and to see if the patient needs to be shocked. What if we also, instead of stopping for pulse checks, we just wait for the right end-tidal CO2 value? Then we still have to stop every 2 minutes to deliver a shock, right? And sometimes when we stop every 2 minutes, it doesn't work. We shock, patient doesn't come back, so we have to keep going. We introduced a harm from the pause, and we didn't get any benefit from the shock. So what if it were possible to only stop when you were absolutely sure that the shock was going to be successful? What if there was a way to do that? Then you just keep going. There's no pause every 2 minutes. You just keep going until the magic things happen. And one of the magic things could be, now the patient is going to respond to your shock. And I think that this is coming. There is technology that can analyze the ventricular fibrillation waveform, and it can make predictions and say, at this waveform, your shock is not going to be successful. It's not in the patient's best interest for you to try to shock them now, because you have to introduce the pause. Instead, keep going. And then when the waveform changes to the configuration where the machine is sure the patient is going to convert, then we'll stop you and we'll tell you, now do it, now deliver your shock. The patient will survive. So that's coming as well. Any questions? All right, so end-tidal CO2 has also been suggested if we take this in the opposite, because we're looking at increasing the numbers to tell us about the chances of surviving. Well, can you then use waveform capnography to determine death? And in an evaluation of 150 out-of-hospital cardiac arrests, they found that at the 20-minute mark of the resuscitation, that no patient that had an end-tidal CO2 value of less than 10 at 20 minutes ultimately survived the cardiac arrest. And that all of the patients who had numbers greater than 10 did survive. Now, they weren't all neurologically intact, but they all were able to survive for short periods of time. And that study has actually been replicated in a much, much larger study that seems to suggest that there is a number, there is a magic number. And if you can get them above this level, they can survive. But if they can't get above that level at 20 minutes, and you're sure that your CPR is good, then they're not going to survive. So at this point, American Heart is reluctant to specifically choose a number. They do make this point that the chances of you getting someone back at the 20-minute mark, if their end-tidal is below 10, the chances of you get them back is pretty much zero. But American Heart's not quite ready to take the step and say, this is the number that you can use to determine death. So all of the experts say, this is probably true, but there's a lot of other factors below 10 that could be coming into play here. And so don't use end-tidal CO2 as your sole predictor. You have to look at other factors to determine whether the patients are going to survive. So I looked at your protocol to see if end-tidal CO2 is even mentioned as one of the predictors of death, or one of the criteria that you can use to determine, to terminate a resuscitation attempt in the field. And what I saw was this. So here's your criteria. And end-tidal CO2 is not considered to be one of the criteria. Right, so you don't use end-tidal to make your decision. But what it says is that the officer in charge can terminate the resuscitation. Your patient has to be non-pregnant, non-hypothermic, greater than 18, and have all of these things present. So the arrest was not witnessed by you or bystanders, no bystander CPR, never received a rescue shock, never had ROSC, and after 20 minutes, no persistent EKG activity and no clinical signs of life. Then that's a dead person. You can terminate that. How do you guys feel about termination in the field? Are you comfortable with terminating them in the field? Is anybody uncomfortable about that?
Depends on the patient.
Depends on.
Yeah, there's always those situations where if the family's not accepting it, then you might not want to. But assuming that the family is okay with it, you guys feel fairly comfortable here. Do you do that a lot? Do you terminate resuscitations much here? What's your transport time? Short, okay.
Really short.
So do you have I didn't notice whether your protocol requires you to perform resuscitation on the scene for a certain period of time before you move?
No.
It doesn't. I'm sure the Lucas plays a role in that.
Yeah, we've had some at the nursing home where you're 20 minutes, working over, they're still in Sicily. Entitle's 40, pulse ox is 100, but you pause the Lucas and they're in a Sicily for 20 minutes straight. And, I don't have any issues saying that patient doesn't need to go to the hospital.
Yeah.
At that point, where we've done everything we can do. Intubated, King 2, IO, all the meds, everything's on board, and they're still in Sicily in 20 minutes. They're not going to magically change in 21, 22.
I agree with you 100%. All right, so the other thing that I wanted to mention was there are some other things to consider as well. So when you have a patient, so now we're out of the dead. So we've already pronounced people that are dead who are dead. Now we're back to cardiac arrest that are surviving. So we got ROSC. Now one of the things that you're going to notice after ROSC is that end-tidal CO2 values are going to go up. They're going to be much, much higher than what you would expect. They're going to be well outside the normal. And the reason for that is that this extra CO2 is what was out in the tissues that you couldn't get to with perfusion from chest compressions. And now that the heart is pumping, it's pumping blood and it's washing out all that carbon dioxide that was out in the tissues. So CO2 values are going to go up. Now it's very tempting then in the post-resuscitation period, when you've got the patient intubated and you're bagging them, it's very tempting to start bagging them a little bit faster to try to blow off all this extra carbon dioxide that they have. But you want to be very careful about that, because as you start to bag them faster than normal, you start to increase the pressure in their chest. The intrathoracic pressure starts to go up. And the heart then is surrounded by this space. And if you start to increase the pressure in this space, then the heart starts to get squeezed. And the blood vessels that are coming in trying to serve this heart get squeezed down as well. And so the heart is going to essentially be able to pump out of this high pressure zone, but the fluid is going to flow into low pressure zones, and it's going to be very difficult for it to make the circuit and come back into a high pressure. And you guys are firefighters, you know that fluids don't flow from low pressure zones in the abdomen into the high pressure zones of the thorax. So if you create high pressure zones by breathing patients too fast, blood is going to flow out of the chest, but it's not going to flow back. And so the patients will go back into cardiac arrest. You can take patients with ROSC and bag them to death. If you start bagging them fast, they'll go right back into cardiac arrest. So be very careful about that. A couple of other things that you might want to keep in mind is that there are some things that can affect your end-tidal CO2 values. So we already mentioned that overventilation, well, even during the cardiac arrest, when we're trying to achieve a 20 or 25, If you have someone that is attached to BBM and they're up there not paying much attention to your endotracheal tube, and they're not paying much attention to 10 compressions and 1 breath, 10 compressions, 1 breath, and they're just squeezing that bag, first of all, they're working against you by pressurizing the thorax, so it interferes with cardiac output or cardiac return, and then they're also bringing the end-tidal CO2 values down. So you look over at the monitor and you see, well, I was at 20 until I started letting you bag the patient, and now my end-tidal CO2 is at 12. And I'm pushing at the same depth that I was, but it's because you're ventilating the patient too fast. Epinephrine is also a medication that will affect your end-tidal CO2 values. When you give epinephrine, you get vasoconstriction. And vasoconstriction also is the vessels that serve the lungs. So you're going to have less blood flow to the lungs, end-tidal CO2 values are going to come down. So if you were trying to make some decisions about termination of resuscitation, and I realize that it's not in your protocol, then you want to be careful about making that decision within a minute or so of epinephrine administration. Give the time for the epi to start to wear off, and then you'll see where your patient really is. And then the last one I wanted to mention was sodium bicarb. So be very careful. In our system, in the Biotel system, we actually had at the 20-minute mark that the end-tidal CO2 value had to be below 20 as well. And if they were above 20, then they couldn't terminate the resuscitation, regardless of anything else. So we actually did a study to look at what percentage of our patients had end-tidal CO2 values that were above 20 that ended up with termination of resuscitation anyway. And what we found was that lots of patients that were above 20 that were getting terminated. And then when we went to look at the charts, those that were above 20, almost all of them got sodium bicarb in the last couple of minutes of the resuscitation. It was the last ditch effort to try to save them. So you gave them the bicarb, and then 2 minutes later you're making a decision to terminate, but their end-tidal CO2 was through the roof. And the reason for that is that when you put sodium bicarb into an acidotic environment, the chemical reaction actually creates carbon dioxide. And so you're actually giving them a medication that's putting more carbon dioxide into their system, and now it's washing through their lungs. CO2 values are going to go up. So if you were going to consider termination of resuscitation, don't give sodium bicarb towards the end of the resuscitation unless there was some real reason for you to give that medication, because it could interfere with an interpretation of whether this patient is attempting to achieve ROSC or not. Okay, questions? Why don't we take a break and then we'll come back to our case review. Before we move on, as this case is, we're going to use capnography to make some decisions about our patient, but we're not really going to be focusing on the waveform. We're going to be focusing on the number and what the number means. So just again, as a reminder, everybody make sure that you sign a roster before you leave and grab a CE certificate. And then you probably are familiar with this case format. We've done it before, where the case is going to unfold as if you were actually running a call, and then we're going to stop along the way and talk about some issues. I did try to make sure that I understood your protocol for how to manage this particular patient. So it should be compliant with your protocols that were issued in, I think February was the last date there. Okay, so here we go. Here's your dispatch information. So you are all being dispatched, whatever your group is, to a 40-year-old female who is reportedly unconscious and unresponsive in the bathtub. So what do you think about when you respond to this kind of call? This is all the information you have. Overdose? Okay.
Sleeping.
She might be sleeping.
Sleeping in the bathtub? Yeah. Okay. Maybe whether she's still in the water, whether she drowned, is she in cardiac arrest? We don't really know any of that information. Okay. So who goes to this kind of call? Will this be a medic?
Everybody.
Two medic, and the medic would have 2 paramedics, and the engine has 4 people, 3 people. Okay. And some of them will be paramedics as well. So conceivably, you could have 5 paramedics here. Okay. But a minimum would be 2.
Minimum would be 4.
Then only
Okay.
4 and D.
Thank
Okay.
you.
Is your department all paramedic?
No.
Okay, okay.
No.
Yeah, we got 3 EMT, 2 EMTs
I'm
now.
only empty in this room right now.
Gotcha,
Yes, 3
okay.
and D, yeah.
Good to be blue instead of red.
That's D-stick D.
I love it. Okay, so let's get on the scene. Here's what we find out. So there's a woman that's on the scene who meets you and brings you into where the patient is. She's still in the water. She's still in the bathtub. There's vomit in the water. The patient is unconscious. The woman who let you in says that she's a coworker and that her friend didn't come to work today, so she came over after work to see what was going on. She had a key, so she let herself in and she found her in the bathtub. And she says that the patient has recently separated from her husband of 10 years. So there's no alcohol that you can see anywhere. There's no guns. There's no knives or anything else. It's just this woman in the bathtub with vomit in the water.
Is she submerged under the water?
No, she's got her head back against the side of the tub, but she's not in the water, or not facing the water. So we're going to have to look for pill bottles to see if we're going to find some here in just a moment. But first, let's do our primary assessment and see where we are. So what we see is that there's a small amount of vomit in her oral cavity. She's tachypnic and she has very poor chest rise. She has +1 radial pulses, which means that they're faint but detectable. Her skin is pale, cold, obviously wet, unconscious and unresponsive, and there's no evidence of trauma. So I wanted to just point out that one shorthand way to record pulse information is this pulse intensity scale. And so you could use numbers, with 3 being a normal. You could say, for example, +3 pulses in all extremities, which would give an indication, whoever's reading your chart would know that you checked, by your documentation, you checked pulses in all extremities and all of them were normal. Or you could say that you have +3 on the right, but +2 on the left. So this is one shorthand way. If you said upper extremities +1, then you know that the upper extremities you've got faint but detectable pulses, but that from that documentation you didn't check the pedal pulses, which would be fine in this particular case. We just want to make sure that she has a pulse. All right, so what we find is here then that she's got faint but detectable pulses. She's tachypnic with poor chest rise. There is vomit in her oral cavity. Those are obviously things that are important to us, unconscious and unresponsive. All right, so what else do you want to know about her?
What's her pupils?
All right, so pupils, and we also probably want a good set of vital signs. We're going to get her out of the tub, I'm assuming, as well.
Suction, start bagging. Okay.
Suction, bagging, and an OPA. Okay, I think those are all good first moves. And about this time, you also have your full set of vitals, and here they are. So I'm going to let you sort of chew on those for a moment, and then we'll pick out the things that are concerning the most to you. So tell me what you see here that is the most concerning, or what are you concerned about?
Someone's just laying there and their heart rate's 130.
That is absolutely. So keep in mind that tachycardia in an adult is always abnormal. Right? Heart rate's over 100 in adults is always abnormal. Now it could be, you have to find an explanation for that. Sometimes the explanations are very simple. Right? If I climb a flight of stairs, my heart rate's going to be over 100. So it would be easy to explain why my heart rate would be up. But here at 132, and as you point out, this is someone who's been laying unconscious and unresponsive for a period of time. That is really high for someone you would expect. And we don't know much else about her at this point. She's also tachypnic at 34. That's an abnormal number. What else are you concerned about?
That should not be hypothermic.
Yep. So yeah, her temperature's low. She's been laying in this water that's now cool. So if it was warm water when she got in it, she's been laying in it long enough that the water's come to room temperature. She's got SpO2 is also normal. I think your protocols use 93 as a cutoff. Is that right? So she would be hypoxemic by anyone's standards. All right. So it doesn't make any difference on the pulse oximetry numbers. There's universal agreement at 89 and below that is hypoxemia. All right. There's not universal agreement on what 90 and above means. But there is universal agreement on what 89 and below means. So she's hypoxemic. What else? Of course, Glasgow coma. That's abnormal in 3. Okay. Anything else anybody want to comment on? All right, so now that we're bagging her, we've suctioned her airway, we've put in an oral airway. Would you put her on a monitor? Okay, you do, and this is what you see. It might be hard for you to see, but it's a sinus tachycardia with some PVCs, multifocal PVCs, yep. All right, about this time, whoever it was that you sent to look for pill bottles has come back and has found some information for you, and you're talking with the woman who's there in the house as well. She doesn't know a lot about her, but she knows a little bit, so here's what you learn. Oh, and by the way, if we go back to the vital signs for just a second. So there's a couple of other things here that we didn't really mention, but this end-tidal CO2 is well outside of the normal range, right? It's a little bit low. And her glucose. What is your cutoff for hypoglycemia in your protocol? I didn't actually look that up. It's 80. So below 80, you would treat with a 10% dextrose solution. So she's hypoglycemic by your standards as well. Okay. All right, so now then we have all of our samples, starting to get some sample history. We don't really know about her meds or her allergies, but these are the the only 3 pill bottles that can be found is a bottle of Xanax, a bottle of Paxil, and a bottle of aspirin. So when you start counting through these medications, well, first of all, what is Xanax used for? It's an anti-anxiety medication, panic disorders, those kinds of things. Why would she be taking Paxil? It's an antidepressant, yep. And then aspirin, everybody has aspirin in their house. So those are the only pill bottles that can be found. Now when you start counting them out, all of the Paxils are counted for. There's 20 of the Xanax that are missing, and they're 0.5 milligram tablets. There's 20 of those missing. And there's nothing in the aspirin bottle, so we don't have any idea whether she's taken them or whether that's just an old bottle. We have no idea about that. Okay, and then of course she has that recent diagnosis of depression and anxiety, so those are relatively new medications for her. Her last meal, we are unknown, but she did have that vomit. And then we don't really know much else about what's going on here. We don't find any alcohol bottles, so we're making an assumption that alcohol's not involved. The vomit doesn't smell like it has alcohol in it. There's no chunks of anything that we can see. There's no pill fragments in that vomit that we can see as well. So if she overdosed on these pills, she didn't throw them up. So they had already been absorbed into the system before her vomit, or she vomited first and then took all these pills. She would have vomited in the tub and taken the pills. Okay. So does anybody have any questions about this before we move on? So one of the things that I want you to be thinking about is whether this Xanax can account for what we're seeing here. And remember that Xanax is a benzodiazepine. So it's in the same family as midazolam, as Valium. It's in that same family of medications. So let's complete our assessment of this patient. Here's what we find. The pupils that you asked about earlier, they're sluggish, but they do respond. They're 8mm size. She has no JVD. Auscultation reveals rolls and rhonchi with positive pressure ventilation. You can hear that even if somebody's bagging. There's no hyperresonance. Whoever on your team did that, while you're listening or trying to produce the sounds. Obviously, she's pale, cold, and wet, but pretty much everything else is unremarkable about her. Okay, so now we come back to that question. Do you think that this is an overdose on Xanax? Would Xanax overdose 20 of those tablets account for what you're seeing here? Okay. Because what we have of the information that we have available to us is possibly 20 tablets of Xanax and possibly some aspirin, unknown amount. If we take worst case scenario and she took all 500, it's a 500 tablet bottle of aspirin, regular strength aspirin. So that would be about 162 grams of aspirin if she took all of those. And so the question I think becomes then, because, well, first of all, can benzodiazepine overdose produce altered mental status like she has? Can it produce coma? Sure it can. As soon as the Xanax would take effect, the patient would start to get altered mental status. Does altered mental status occur with aspirin overdose? It can happen, but it's usually very late in an aspirin overdose. It's not something that would happen early, but it could happen. All right, will benzodiazepine toxicity produce respiratory depression? Yes. But usually it doesn't unless there's been some co-ingestant. So if you mix Xanax with alcohol, much more likely to have respiratory depression under those circumstances. But we don't have any evidence that there's any alcohol involved, and we also don't have any evidence that there's any other medication that's involved. Benzodiazepines, especially Xanax, are actually quite safe. They're remarkably safe for what they actually do. And in order to overdose on Xanax, you have to take about 330 milligrams per kilogram of body weight. So in a 0.5 milligram tablet, you'd have to have about 600 tablets per kilogram of body weight to be toxic with Xanax. So it doesn't seem likely that this has caused this 10 milligrams of Xanax would actually make her this sick. So that there's got to be something else going on. Right? 10 milligrams, she would need somewhere in the neighborhood of probably 33 grams of Xanax for it to be a lethal dose. And she's only had 10 milligrams. So it's probably not Xanax. So what did we miss here? Well, everything that you needed to make the diagnosis is actually on her vital signs. There were two things especially that should have stood out to you, and that's her tachypnea and hypocarbia. So here, and again, you also should have known, because this is a capnography lecture, that the CO2 was going to come into play here. And so the CO2, we're not interested in the waveform, we're interested in the number here. And so this is hypocarbia. And what aspirin does, one of the things that aspirin does at toxic levels is that aspirin will cause the respiratory centers in the brain, it will stimulate them. And so patients who hit toxic levels of aspirin will start to breathe fast. And when they breathe fast, if I have CO2 values that are here and they're within the normal range, and I start to breathe fast, what's going to happen to that normal range? What's going to happen to the value? It'll start to fall, right? Fall outside of the normal range, which is exactly what's happened here. So now, if this is happening, if I start to breathe faster than normal, 36 times a minute, am I going to become acidotic or alkalotic? You guys remember this from paramedic school? I'm going to be alkalotic, because I'm blowing off the CO2 faster than my cells make it. So aspirin produces a respiratory alkalosis. That's what aspirin does at toxic levels. Okay? Now, if you have respiratory alkalosis for a long enough period of time, then it can start to cause problems for you. So the normal compensatory mechanisms of the body, if my CO2 levels start to fall, and there's nothing wrong with me, but if my CO2 levels start to come down, what is my normal compensatory mechanism going to do? Slow down respiration so that I can retain carbon dioxide. Right? But that can't happen here because of the aspirin. The aspirin is preventing that from happening. So she's just going to keep breathing faster and faster and faster. This number is going to keep getting lower and lower and lower because there's so much aspirin, or potentially. We haven't confirmed this yet, but we now suspect that this is the aspirin and not the Xanax. Because if she had overdosed and had a toxic level of Xanax, the respiratory rate would have fallen and the CO2 levels would have gone up. And so this did just the opposite. So it suggested it wasn't the Xanax. And the only other thing that we know about is aspirin. And aspirin does explain those two things. There's some other things happening here that also suggest that this is aspirin. So first of all, the toxic amount of aspirin is about 150 milligrams per kilogram. That will cause a severe toxicity. So for you, on a regular strength aspirin, think about how much you weigh in pounds, divide that by 2, divide that number by 2. That's how many aspirins you would have to take to have severe toxicity. So if you were 100 kilograms, you divide that by 2, 50, divide that by 2, 25. If you took 25 regular strength aspirin and you were 220 pounds, you'd have a severe toxicity. She has a bottle that had 500 tablets, and all she would have needed to take is about 30. She had taken about 30, probably even less than that. Then she could have reached a toxic level. So it didn't take that whole bottle. Questions there? All right, so we're not talking about just a massive amount of tablets here that she would have had to have eaten of aspirin. It could have been something as simple as 25 tablets of aspirin, and that would have been a toxic dose for her. All right, as I mentioned, that in addition to these two things that are explained by aspirin, aspirin does a couple of other things that are also showing up here. So as aspirin continues to be absorbed into the system, and we know that it is, or we suspect that it is, because there's no tablets floating in the water. Now, they could have broken down if she had vomited, but we also don't see any pill fragments anywhere else. So the absorption of the aspirin is probably complete at this point. Aspirin interferes with glucose metabolism. And what aspirin does is it interferes with the ability to get from glucose plus oxygen all the way down here to ATP, water, carbon dioxide, etc. So it interferes with this process. The glucose then starts to get burned at a faster rate because I'm trying to extract energy, but I can't do it efficiently. So I start down the process, but then it just stops because of the aspirin. So then I have to start again, start burning more glucose, So this is what aspirin does. Aspirin allows it to get to the pyruvate level, but then it can't go any further. And when you can't put pyruvate into the cycle to extract energy, something else is going to happen to that pyruvate. And what's going to happen is it turns to lactic acid. And so the aspirin is interfering with the glucose. That's why her glucose levels are so low. She's burning glucose so fast, but she's not getting any energy from it, not very efficiently. And instead what she's doing is she's producing acid, lactic acid, instead of ATP. So even though you have a respiratory alkalosis, metabolically, she's becoming acidotic. Okay? Questions there? You guys remember all this stuff, right, from A&P and paramedic school? It's in there. Okay, now if you become acidotic, what does your body do to compensate for the acid in your system? It increases the respiratory rate to bring the carbon dioxide levels down. And we saw that as well. Now, we also knew that aspirin does it, but it could have been also because of the aspirin doing this. It was contributing to that. Now, what if I saw those numbers, a tachypnea and a hypocarbia, but if I saw those numbers in a patient who didn't overdose on aspirin, but they were a diabetic, would I think respiratory alkalosis? Or would you think metabolic acidosis? If the glucose was not low, but it was high, respirations were high, metabolic acidosis. So we can use capnography to give us some idea about acidotic states of the patient, or alkalotic states as well. The only reason that we went towards respiratory alkalosis in this case was because we knew that that's what aspirin could do. Otherwise, we would start thinking, wow, tachypnea and end-tidal CO2 low, that's probably acidosis. Acidosis would trigger the respiratory rate to increase and blow off carbon dioxide to try to bring acid levels down. And if the patient is diabetic and has a glucose level that's elevated, bam, that's it. This is diabetic ketoacidosis. But that's not our patient, because the glucose levels were low. Is everybody still with me? Okay. So if your body can't get the energy it needs from glucose metabolism, then where's it going to go? It's burning glucose really fast, but it's not getting enough energy. What's it going to do? It's going to start burning fatty acids, which will produce ketones as the byproduct, not carbon dioxide. It'll produce ketones. And so this is ketoacidosis. This is not diabetic ketoacidosis, but this is ketoacidosis. It's being caused by aspirin overdose. So you've got respiratory alkalosis and metabolic acidosis that are occurring in this patient. Now we're beginning to see that this patient's in trouble.
So which one's gonna win?
Ultimately, it's going to be the acidosis.
Our pH, you would expect the less than 7.35 at this point even.
Yeah, if we could measure that, yeah. And there is a way actually that medicine can tell the difference between, because we can't use the end-tidal and the respiratory rate to distinguish between respiratory alkalosis and metabolic acidosis. We can sort of get some idea based on our history of the patient. If this were a diabetic, we would know to go towards the acidotic state. But because it's aspirin, it could be either one. But there's some things that we can't measure in the field that they can measure in the hospital and be able to tell the difference between them. We just can't. We don't have that technology in the field. So we have to go with our histories. Okay? All right. So now, as we mentioned, the normal compensatory mechanisms for the metabolic acidosis, that ketosis that we just saw, would be an increased respiratory rate, which would cause end-tidal to fall, and that's actually what's happening here as well. Now, aspirin or salicylate overdoses also produce heat. They make the patients have a fever. Well, this patient doesn't have fever. Well, how would we explain that? Because if this is an aspirin overdose, she should have a fever, but she doesn't. She's been laying in this water. Yeah, she's been laying in the water. So that may explain why she doesn't have a temperature, is that she's been in that water for a while. Okay. Now, one of the other things that I want to mention, and I tried to figure out where's a good place to mention it, and I couldn't find a really good spot, but this is as good a spot as any. Is I want to talk about, just for a moment, let's step outside this case. We're going to come back to it, but let's step outside this case. If you have a patient that overdoses on aspirin, we see what's going to happen. The respiratory rate's going to go up, and the carbon dioxide levels are going to fall. They're going to start to produce metabolic acidosis. But let's say that this aspirin overdose is recent. Like this just happened 30 minutes ago, an hour ago, not potentially hours and hours ago. So this is a new one. When you have patients that start to get tachypnic and hypocarbic with aspirin overdose, at some point, and we see also here that there's some hypoxemia, why do you think the patient is hypoxemic? What do you think is causing that? Aspiration, yeah. It's also, aspirin also interferes with membrane function, so there's fluid going into her lungs. That was the rales that we heard earlier. But here's the point that I want to try to make. Step outside this. This is a recent aspirin overdose. When patients start to get into respiratory distress from aspirin overdose, this respiratory compensation for acidosis can't keep up with the fatty acid metabolism, the glucose metabolism that's occurring, the acid production that's occurring, the respiratory system can't keep up with it. And they're trying, the patient's body is trying very, very hard to keep up with that acid, but it can't. And ultimately, the compensatory mechanisms are going to fail. When you start bagging this patient, not our patient, but a patient who is conscious, if you were to try to put them down and intubate them and start bagging them, you can expect cardiac arrest. Because once you take them down, even that short period of time that they stop ventilation, they stop that tachypnea, that's enough for them to become acidotic to the point that as the acid levels start to fall, aspirin absorption increases significantly, and they will go into cardiac arrest. You can almost always expect it. So the recommendation from the experts are that when you have breathing patients on an aspirin overdose, let them breathe on their own. Don't try to bag them. Don't try to put them down until they get at the hospital, because there's something else that has to happen before that becomes a safe thing to do. Now, in this case, you've got a decision to make. If you intubate this patient, there's a good chance she's going to go into cardiac arrest. But she's also already vomited. She has an unprotected airway. She has a Glasgow of 3. May have already aspirated. You have an unprotected airway. So what are you going to do? Intubate. Is that pretty much a consensus opinion? Because I don't want to dissuade you from intubation here. What I'm suggesting is that when you make that decision, just be prepared for what probably is going to happen here. Okay? But I agree. If she wasn't to this point in vomiting, I don't think I would intubate her, but she is. And that's why she has to be intubated. But things are going to get really ugly when you do. Okay.
Pretty ugly already.
Yeah, she's in a bad spot. Okay, one other thing that I wanted to mention here is this Glasgow coma score. So as the acid levels, the metabolic acid levels continue, the acidity interferes with membrane function throughout the entire body, cellular membrane. And so the aspirin actually within the brain will actually start to go into the cells, into the brain cells at some point, and shut down the ATP production of the glucose within the brain. And so the altered mental status is going to start to happen. This is essentially the brain becoming hypoglycemic, massively hypoglycemic, because the glucose doesn't get it the energy that it needs. So this is why you see the altered mental status. And now it's about as altered as you can get. You can't get any lower than a 3. And almost always when you get aspirin overdose that starts to cause altered mental status, that precedes the cardiac arrest. You won't have conscious, alert-oriented people that will immediately go into cardiac arrest from aspirin overdose. But once they start to get altered mental status, then cardiac arrest is on its way. Questions? All right, so as our basic level things here, assess and support the ABCs. So we're already making a decision. I think everybody in this room is saying, yeah, because of her state, she's going to have to be intubated. And I think that that's a wise move here. So your protocol also says for unstable patients, you need to assess vital signs at least every 5 minutes, have that documentation as well. Keep in mind that in a study of emergency department patients that had aspirin overdose that arrived by ambulance, half of the patients who arrived by ambulance with aspirin overdose arrived, they were alert when they arrived, but they died anyway. So this patient is not alert. She's already had altered mental status. There's a very good chance that this patient has already crossed the point of no return. She's not going to come back. Okay, we want to do our glucose analysis, and then you're going to manage that. What do you guys think about giving her glucose? You think that's going to help the situation here? No. Not at all, because that aspirin's on board, and she can't use glucose. She can't use the glucose that she has. You can give her more, but she can't use it. And so, by protocol, she would get a dextrose because she's hypoglycemic, but it's not going to do her any good. It doesn't provide fuel, it doesn't provide energy for anything, because the aspirin is prohibiting that. Now, the protocol also, not your specific protocol, because your protocol actually doesn't address aspirin overdose. Most pre-hospital protocols don't. But we're going to come back to this idea about a toxidrome here in just a moment. But we're going to go through just our basic things that you would do for every basic patient, and then move into the advanced things. So we want to put the patient on all of our monitors, which we did. We already have readings for all of those things. Your protocol does say 12 lead for overdose patients. So by protocol, 12 lead would be an appropriate thing to do. Although there's not really anything here in the protocol that gives you information that's going to be useful to you. I'm not telling you not to do it. What I'm suggesting is that it probably has the lowest value to what this patient actually needs. It's busy work. And start your IV, then initiate transport. All right, so now, why was it important for you to be able to distinguish between benzodiazepine and salicylate toxicity? Why did you need to know that? Because you could have done all of these other things even if this was a Xanax. The reason that you needed to know the difference is because of this, your transport. If this is, where would you transport this patient that we just saw? Where does that patient go? Does it depend on where in the city you are?
Probably.
Okay.
You're out of the alley.
The only chance that this particular patient has to survive is that they have to get to a center that can do emergency dialysis. If she can't get emergency dialysis, she's not going to survive. If it's a Xanax overdose, she doesn't need emergency dialysis. But if it's an aspirin overdose, that's the only chance she has. There's nothing else that's going to fix her. And so if you transport her somewhere that then has to make arrangements for them to do emergency dialysis, transfer to another facility, it's just a delay. And remember as well that we've already intubated her, and we probably are going to put her into cardiac arrest during transport if she hasn't already before we leave the scene. And so, again, if you transport her to the closest facility, she may end up at a facility that can't give her what she needs. And you're not going to get her back without putting her on emergency dialysis. She has zero chance. She has a very poor chance even on dialysis, a very poor chance. So hemodialysis is the definitive treatment for salicylate overdose when you start having altered mental status, when you get to end organ injury. Any questions there?
So you wouldn't want to give sodium bicarb to prolong acidosis?
Great question. That's a great question. So let's go back to here when we were going to start this IV. So what's a reasonable thing to do, it's not in your protocol, but a reasonable thing to do is when you, what size IV bags do you use? Do you, thousands? When you hook up the 1,000 cc bag, a reasonable thing to do would be to put 2 or 3 amps of bicarb into that IV and let the IV flow with sodium bicarb in it. It's not, it'll buy her some time, that's all, but it may help a little bit. Because one of the things, again, what we have to make sure is that, so as the acid levels rise, as pH levels begin to fall, when she hits a certain point in the pH, the membranes in the brain are just going to open up and that aspirin's going to cross over. And that's it, she's done at that point. So what the bicarb may do is help keep her from going any further down until she can get into this dialysis. So it is absolutely the thing to do. But it just buys time. That's all it does. And I suppose you'd have to call your medical control and have them authorize that. But that's what she needs. Okay, she needs the dialysis, not the bicarb. The bicarb is okay, but she's got to get to dialysis. Okay, so here is the toxidrome table, and I know it's very, very difficult for you to read, and that's okay. But I want to just mention toxidromes for just a moment. I think that every paramedic on an ambulance ought to have access to a toxidrome table. Maybe it's something that you have in the ambulance, or something a resource that you could get to online. But what toxidrome tables are is you have different kinds of toxidromes. I think there's about 10 of them. And a toxidrome is a toxic syndrome. So it is the signs and symptoms that are associated with certain classes of medication. So here you can see different parts of an assessment findings based upon different medications, classes of medication. And so Xanax would be a sedative hypnotic. Okay, so the benzodiazepines are sedatives. And if we look at a normal, if we hadn't figured out the aspirin issue earlier, and we go, okay, let's see, maybe this is a sedative overdose. We can see that they should have bradycardia, hypotension, bradypnea. She didn't have that. She did have central nervous system depression and coma. She had that. But these things are not here. Some of these things are not here. So it suggested that this was not the case, that there was something else here. But if you look at this, for example, with where do I want to look? Here, sympathomimetics, I knew they were here. So sometimes when you're dealing with a patient on the scene, that patient who's the agitated delirium patient or excited delirium patient, you may not have a clue as to whether did the patient take cocaine, did the patient take methamphetamine, what was the medication that they took? Don't have a clue. But all of them, regardless if it's a sympathomimetic, are going to produce these kinds of signs and symptoms. So when I see these kinds of signs and symptoms, then I think this is sympathomimetic toxidrome. And so I'm going to treat them just like I would any of them, treated exactly the same. If it's an opioid, I don't know whether it's heroin or methadone or fentanyl, I don't know what it is, but they're treated the same because they all have the same signs and symptoms. They're all part of the same family of medications. So for the EMS world, it's almost impossible in some cases to identify the exact medication that patients have taken. But if you can identify the signs and symptoms, the group of medication, it'll give you some idea about how to manage them. Aspirin doesn't have a toxidrome, unfortunately, so it's not going to be on here. Any questions there? Okay, so as far as our advanced things, these are some of the points that we made already. So advanced airway management, positive pressure ventilation, it just can't keep up with the metabolic demands of the aspirin toxicity. And so these patients have got to undergo hemodialysis. And when you start tinkering with the airway, advanced airways, positive pressure ventilation in these patients, especially when they have altered mental status, then it presents a no-win situation. You are between a rock and a hard place. If you don't manage that airway, then you made a mistake. And if you manage the airway, then you made a mistake. And ultimately, that's going to be the argument, right? If you don't manage the airway and this patient dies, somebody's going to say, why didn't you get control of this airway? And if you intubate her and she goes into cardiac arrest, somebody's going to say, what the hell were you thinking? That's what aspirin overdoses do. So you're in a bad spot here. You have to decide what you're going to do for this patient. And there's just no win. It's a no-win situation. She's going to deteriorate anyway. You have to make that decision. And that might, that's just a crappy spot that you're in as a paramedic, but that's what paramedics do. Get themselves into crappy situations and then try to get out of it. So, I feel your pain. Questions there? Okay, so salicylate toxicity, also volume deficit, so they may need a little bit of fluid. And as I mentioned, putting in some sodium bicarb into that fluid is a reasonable thing to do. The experts do recommend perhaps 3 amps of sodium bicarb into 1,000 cc's and let it run about 2 or 3 cc's per kilogram per hour. So at a pretty brisk pace. It's not going to hurt anything. This patient, especially our patient here, is on her way out. And this is something that would be an appropriate thing to do. And now that you know aspirin overdose that has altered mental status, whenever you call your receiving hospital or you call for orders, you should say, how about putting some sodium bicarb in her bag?
What was the rate again?
It's a 2 or 3 cc's per kilogram per hour. Okay. Questions there? All right, so here's our key point. So whenever you can identify specific toxidromes, it's always the best thing to do. Toxidromes are an easy way in the field to sort of get an idea of what you're dealing with and kind of approach to the patient. If you have a patient that is an aspirin overdose but they're breathing on their own, let them breathe on their own as long as you possibly can. But there may be a point where you have to make a decision. Just recognize that the complication rates are going to be very, very high in these patients, and you're taking you have to just be willing to manage the complications that you create by giving even appropriate therapy. And then hemodialysis is what they need. They've got to get to a facility that can do that. So your transport destination for aspirin overdose patients has got to be a facility that can get this done very, very quickly. And I have no idea where that is. So that's something that you'll have to figure that out. Okay. All right. Well, that's all I have. There's my email address if you guys have any questions or complaints. Don't forget to sign the roster on your way out. Pick up a CE form. I appreciate your